Welcome, everybody. My name is Bill Bullman. I'm the Medical Director for Lung Cancer at Verisight, and I am very proud to welcome you to our webinar, a novel genomic test to provide objective clarity in early lung cancer risk assessment. We are joined today by Dr. Carla Lamb. I'm going to be speaking briefly after Dr. Lamb, and then that'll be followed by a section by Dr. Hans Lee. So Dr. Lamb joins us from Leahy Clinic in Burlington, Massachusetts. She is the director of the Interventional Pulmonology program there. She is the director of the Interventional Pulmonary Fellowship there, and she is going to be talking to us about challenges in lung nodule assessment. Thank you, Dr. Lamb.
Active webinar, and we look forward to a lot of interaction from the participants. So I'm really going to speak about, what are the challenges in lung nodule assessment. I think we are all more aware than ever about the lung nodule, and I think it's really been spotlighted over the last decade in the face of lung screening and how we approach the nodule in general, and how do we refine our approach. And I just want to make a comment. I think, the scale of the issue with lung nodules is that it's important not only to distinguish the incidental lung nodule and appropriately contextualize and strategize and risk stratify, if you will, the patient who has the lung nodule that's picked up incidentally, and also, again, think a bit differently about the patient who is in the defined high-risk category, who comes in asymptomatic for lung screening as a participant in lung screening over the initial scan and then beyond. And I think it's important to highlight in general, when we look at nodules, the scope and scale, and the number will only rise. As we all know, just recently the USPSTF made a recommendation to change the lung screening inclusion criteria to a younger population beginning age 50 with a lesser PAC year history of 20 PAC year. And so again, I do think it's important as we approach the nodule, there's some unique differences between the incidental nodule and then the highest of the high-risk patient population who's undergoing true intentional lung screening, and how do we marry those groups together in a meaningful way to best stratify patients who can be followed radiographically or those who need further interventions sooner. And the ultimate goal is to get proper patients, the correct patient, to a lung cancer diagnosis at its earliest stage, and at the same time not subjecting patients with benign disease necessarily to more invasive procedures. I wanted to highlight this slide. Again, this is really a step into NLST lung screening. I'm distinguishing with this slide. I think what I'd like to really highlight for the group is that when we think about false discovery rate and false positive rate, they are not mutually the same. And what I mean by that is we've come a long way over the last decade. When NLST first came out with the lung screening, it was often quoted, and it continues to sometimes be misquoted in our literature about the high false positive rate. But I wanted to use this opportunity as we're focusing on the lung nodule to dispel that and to really clarify. And what I'm highlighting here using the NLST data is looking at the true specificity, the false positive rate here in a patient who has a false positive finding on scan, again, compared to true negative. So again, taking that numerator of false positive and adding that to the denominator of false positive and true negative, the actual false positive rate based on the NLST data was 23.5%. And what's really come into the timeline that we've been doing lung screening is if you think about lung RADS implementation in North America, that's one of the validated tools in which we stratify patients who have had their initial baseline lung screen, then T1, their subsequent screen, and then a subsequent screen going through 3 rounds. If we look at what was published by Penske in the Annals of Internal Medicine, they looked at the NLST and they applied the lung RADS, which was not, again, that was not then, was not present during the original NLST. And if you look at the initial scans, the false positive rate for those patients getting screened was actually 12.6%. And on subsequent scans, those numbers came down to even further false positive rate, being lower, 5%. And then in the journal of the JNCCN, again, McKee and colleagues also published similar overall false positive rate using lung RADS over 3 sequential screening scans is only being 7.6%. So I wanted to use that opportunity to really clarify that. But I do think the point now moving forward is how do we, again, false positives, there's still a false positive rate, although the numbers have a false positive in the screening population continue to decline because of the tools we're using. So I'm going to walk us through a case. I'm really hoping that everyone will use their polling opportunity when the questions come up. But, you know, lung screening or the incidental nodule, we still need to clarify, and this is going to highlight the incidental lung nodule here. This is actually a 77-year-old Caucasian male. He quit smoking fully 2 years prior to presentation. He has a 20-pack year tobacco history. And he does a lot of traveling to Arizona. He's an avid fisherman and a hunter and does a lot of camping in Arizona. Now, subsequent to this, he actually came in for shoulder pain. So he was not really presenting with any pulmonary symptoms whatsoever, but had shoulder pain that prompted plain imaging of his shoulder that caught a peripheral lung nodule that then prompted further evaluation, as I'm highlighting here in the right upper lobe. He had, because of his travel history, a coccidiomycosis titer was performed, and it was 1 to 4, and sputum culture, although he could not produce, was induced. It was negative. And then if you see here, you can define this nodule as being right upper lobe, peripheral base, 15 millimeters in size, and he underwent a subsequent PET scan that showed really faint uptake with an SUV less than 2. So if I could just ask the audience, with that history, again, the incidental nodule, could we all kind of vote where we put that in either high, moderate, or low risk for a possible lung cancer in this context? I want to give everyone a moment to do that. Thank you for responding. I think this really is an example of something that, a case scenario that we may come across in a routine day-to-day outpatient clinic. All right, so we can see there was really a mix between where we would rank this, but I think the majority from the polling identified that they thought it would be more intermediate to moderate. Let's discuss it further. Things that I want to highlight from this conversation. I've kind of given you all the buzzwords of how we either could use clinical intuition, if we have a lot of experience seeing nodules. We take into account the patient's risk factors, their age, the appearance radiographically by a number of different features being defined of the nodule. And I want to make an addendum here. The Mayo calculator, there's many different calculators. I actually plugged in several different calculators, the Brock, now known as McWilliams, and then the Mayo Clinic, including the PET scan. And if you had a PET scan, and if we all agreed that this was a spiculated nodule, the Mayo calculator in full would give us a score of about 52% probability. However, if we plugged in, again, the variations of the calculators that are available, namely the Brock or McWilliams calculator, again, looking at age, the appearance, they have a family history of malignancy, history of emphysema. There's different things that are incorporated that distinguish the two calculators. The range of which we might do get a performance or a probability from a calculator could be anywhere from 21% to 52%, but still keeps that patient in that intermediate risk category beforehand. So I think that's an important point here. So let's take it the next step. So you have that information. I'll give you that between whatever calculator you've chosen, you're getting a probability between 21% to as high as 52%. with that information, if we could all exercise our polling, options are bronchoscopy with navigation, CT surveillance for 3 months, transthoracic needle aspirate either by a spin-perk modality or radiology by our interventional radiologist, or a surgical resection. And let's see how what everyone's thinking. I see the poll shifting. I appreciate that. I think this is the real world and how we determine our next steps. And there is kind of a mixed review, and I think some of the nuances, let's talk about some of the nuances here and how we might choose one path versus the other. And it's not a definitively one path only answer. So a few things to think. I think we can end our poll and then dig a little bit further into the case. And so this actually builds on the complexity of our decision-making. Again, remember, it's not just physician decision-making. It's also going to be patient-centric, shared decision-making, collectively going through this together. Identify that, the patient could have his FEV1, which I'll give you now, is FEV1 of about 1. And his DLCO is 47% predicted. He's functional. He's not oxygen dependent. He's able to hunt, fish, and do leisure activities, as I mentioned. But this is not the type of nodule where, an IR biopsy, I think the risk of pneumothorax is there. Navigation bronchoscopy, whatever navigation you might choose, could be an option. And then obviously surgical resection. I think the majority of the group felt that not observing, although it could be an option, the majority chose to take another step. And this kind of leads us into our discussion for today in terms of, where do we go from here? And so if we look here, the patient did undergo a bronchoscopy. There were no mediastinal lymph nodes to speak of, and the navigation, unfortunately, did not render a tissue diagnosis. And so with that, I'm going to move us down the poll a little further. So with that information, we've taken a next step approach with bronchoscopy, but unfortunately did not get a tissue diagnosis. And so now where might we go with the next steps? All right. So it looks like there's, again, a bit of a mix here. Some would follow a short interval. Some would do a transthoracic needle aspirate. Some would offer a surgical wedge resection. All right, let's move along, and we'll lead further into the discussion. So this is where I would say, wouldn't it be helpful to utilize another non-invasive tool potentially to shift us from that patient who has the intermediate risk, but has measurable enough risk that we would want to have some sense of which direction to go. Could we safely and comfortably and reliably to the patient inform them we could follow this, or could it be something that would tip our scale to take another intervention more definitively? And I think this highlights here from a number of published peer-reviewed reviews determining that lung cancer risk remains always a challenge for both patients and their decision-making, as well as providers trying to offer them the best evidence-based guidelines and practice. And so we have to think about in the screening population, even though the high-risk population, 95% of those nodules are not going to be cancer. The order is about 4 to 5% incidence, and that can vary. And we're still seeing about a 30% incidence of patients undergoing surgical lung biopsy as part of their algorithm, and that be a granuloma or a benign etiology. And then, interestingly, 75% of the time physicians are opting for less aggressive management of patients for whom surgery would be recommended by guidelines, which highlights that we are not uniform as providers providing care for lung nodules. We're not uniform in our practice of providing and actually acting on and fulfilling the guidelines that are suggested in our peer review journals. So room for improvement. So this is actually something I think we'll be familiar with regarding the CHEST guidelines recommending how to assess the probability of cancer to guide further next steps in management based on a new solid indeterminate nodule measuring anywhere from 8 millimeter to 30 millimeters in size. And it's important to always identify what the patient's surgical risk and ability to recover from surgical endeavor. And if we walk through the guidelines a bit further, walking through this algorithm, while it is helpful and it is evidence-based, it really calls for still further integration of how we refine our risk calculators, our own clinical intuition, which is a combination of that, and then how do we put it into practice in a meaningful way that helps us get to that end goal of early detection of cancers and proper treatment in a timely fashion while not pushing patients through for biopsies for benign diseases and moving them through treatment. And so we have, patients often land up in this category of low to moderate risk, 5 to 65%, based on all the different benchmarks of calculators. And I think that makes the decision, that's really the bane of our challenge, is to figure out how to better stratify these patients to see if we can move the trajectory of their care plan. So I've already kind of mentioned that, and I think it's worth mentioning also when we think about these predictor models, what are we doing to factor in? Depending on which model or risk calculator you use, it's going to be built upon oftentimes the patient's prior history, their family history, other comorbidities in the context of what we can do procedurally to get them safely through, radiographic features, upper lobe, spiculated, non-calcified, size. All those things are part of the equation that we may be intuitively putting together, but also trying to form information where you could actually give a patient a percentage of risk that they could conceptualize and really think about in their own decision making. And how can we further stratify them between high, intermediate, or moderate risk and low risk? This is important. The physician-assessed risk, this is actually published and looked at in a number of different venues, breaking out really the Mayo and the Brock calculators are highlights, and also the VA calculator, looking at how do we compare with risk prediction models. They're valid based on populations, but we have to proceed with caution in these, because if we're using or applying a risk calculator in a population for which the risk calculator was not developed, it can grossly underestimate or grossly overestimate the patient's inherent risk for malignancy. So we do have to be careful in terms of how we apply these. And Gould and colleagues actually took the NLST subset population of patients who had 8 millimeter nodules, again, specific to the lung screening, and they looked at patients who had between their first baseline scan and their first round and captured that and applied these risk calculators in terms of the Mayo, the Brock, and the VA, and it appeared that ultimately the Brock performed the best, although they were close. And then Tanner and colleagues looked at physician-assessed risk formation and decision-making compared to the calculators. And oftentimes, as I'll highlight here, you'll see that physician-assessed risk has been found to perform better than risk models in a number of different sections. Let me highlight. This is physician assessment or assessed risk in the pink or maroon. And when we're good at the high-risk patient, we're better than some calculators in the low risk, but the intermediate, there is room for improvement. We need more than just our intuition to help stratify these patients. This is another example that I think highlights when you look at the different nodules that might be considered radiographically higher risk and patient scenarios that are kind of plucked out here regarding risk factors, and putting them through all the probability models. Look at the variance across the board. You'll see Mayo and Brock and VA are probably the most comparable to each other, but I think it is important, again, when we can't universally apply these calculators in all comers, and that's a very important point. And I think as the McWilliams/Brock calculator has evolved, it's made it more simple. The Brock calculator, again, the Brock-McWilliams calculator, as I've mentioned, and then the Mayo Clinic actually is enhanced by if you have the the benefit of having a PET scan that's part of that. So I think, again, what I would have you, as we move through the conversation, is that, patients and physicians, we would like to give our patients as much certainty as possible so we can help inform their decision-making and answer their questions with as much evidence-based information as possible. And I think it really is incumbent upon us as kind of gatekeepers of the pulmonary nodule, whether it be incidentally found or be through a very intentional lung screening program. The same rules apply in the sense that we need to find better ways of stratifying. And so is it possible, by adding a non-invasive addition to what we currently have, to further move that dial for patients? And this is just a highlight as we lead into this. If we could identify, just by some additional data that's validated in the proper patient population, where we could actually insert this into a clinical pathway to allow us either to move them down the risk to a lower risk category if they're intermediate, or push them into a higher risk, prompting further and more robust evaluation. That can be meaningful and could be a game changer. So I'll stop there, and we'll let this lead into Dr. Ballman's presentation and Dr. Lee's. Thank you.
Very much, Carla. So Dr. Lamb sort of laid out the lung nodule landscape for all of us, and I'm going to leave this slide up for a moment because I'm going to now talk about the Verisight's Percepta nasal swab, which is Verisight's efforts to use genomic information, highly personalized genomic data from individual patients to inform on the risk assessment in a patient with a newly identified pulmonary nodule, specifically former and current smokers with a newly identified pulmonary nodule. The idea being that we can use genomics to enhance the risk stratification that we can do with clinical data alone, and more accurately bucket patients into low risk or high risk categories, or appropriately into the intermediate risk category, so we can rule out more cancers in patients with benign disease, rule in with more confidence patients with cancer. So just a few words about myself. I am very new to the Verisight team. I had an opportunity to hear about the exciting things that Verisight was doing in the lung cancer space, and was offered an opportunity to join them. I've only been with them for a few months. Prior to that, I was the director of bronchoscopy at the Columbia University Medical Center in New York, where I've been had been for 26 years. And I also served as the director of the Lung Nodule Assessment Center. So this was something that I did on a daily basis, and now I'm helping, along with the Verisight team, to bring the nasal swab to the pulmonary community. Just a few words about Verisight. Verisight is a global genomic diagnostics company. It was founded and headquartered in South San Francisco in 2008. It is a company that was started with a single classifier for thyroid nodules that accurately predicted which of those were malignant. The company has grown enormously since then into a global company with presence in 7 out of the 10 most common cancers in the United States, soon to be 8 cancers. Afirma was the original thyroid and still is the most commonly used classifier for thyroid nodules. We have classifiers, Medicare-covered genomic tests for thyroid cancer, lung cancer, breast cancer, bladder cancer, and prostate cancer. And soon there will be a colon cancer test in the portfolio. Verisight also has an interstitial lung disease classifier that helps in the diagnosis of UIP. Many of you may be familiar with the Envisia genomic classifier. Most of Verisight's tools utilize the vast amount of data that's available in RNA whole transcriptome sequencing. And the tools are developed using advanced machine learning. Now, there are probably people in the audience that know a lot more about machine learning than I do, but for those of you who don't, machine learning is the process in which a computer algorithm is fed a large amount of data from a large number of subjects where 2 or more outcomes are being studied. And the computer is essentially given that data in an iterative fashion and trained to be able to differentiate from cancer from no, from a patient with a cancer and a poor prognosis versus a patient with the same cancer and a good prognosis. The result is what's called a classifier, something that can see a new set of data, a new patient, and accurately predict the outcome for that patient. The classifier is then validated by giving it an entirely new set of patients for which the outcome is not known by the computer algorithm, and then the performance of the classifier is graded essentially by comparing it to the actual outcome, by comparing the prediction to the actual outcome. That is the technology behind the currently available Percepta genomic sequencing classifier. That is a classifier, actually a risk restratification tool that was developed to take genomic data from the bronchial epithelial cells, benign bronchial epithelial cells, in a patient who has a lung nodule who's undergoing bronchoscopy, in the event that that bronchoscopy is negative and that genomic data is then, non-diagnostic, meaning there's no benign diagnosis and no malignant diagnosis. The genomic data collected in the Percepta GSC from the right main stem epithelial cells is used to take the pretest risk of malignancy in that patient and give a post-test risk of malignancy, potentially up-classifying the risk or down-classifying the risk. A patient with an intermediate risk, for example, could be classified as high risk or even very high risk. High risk or low risk or very low risk. A patient with high risk of malignancy as a pretest probability malignancy could be classified as very high risk, allowing for decision-making, sort of insurance in the event of a non-diagnostic biopsy, guiding the pulmonologist's decisions about what should happen next. The case that Carla presented would be a perfect example after the bronchoscopy for use of the Percepta GSC. It's collected at the time of the bronchoscopy and run if the results are non-diagnostic, as that case was. The Percepta nasal swab classifier is different. It uses the same technology, but it uses it upstream, and it's designed, it was trained in a different set of patients, a different type of cohort, designed to do a different thing. It's designed essentially to do an initial risk assessment, to bring objective, data-driven decision-making to that initial risk assessment where the pulmonologist needs to decide what is the best next step for this patient. Is the risk truly low and this patient can safely go into surveillance? Is the risk truly high and we need to be aggressive? Or is the risk intermediate and we need to do some non-surgical sampling in alignment with what the ACCP guidelines tell us to do? So essentially, the nasal swab classifier developed in former smokers is designed to do that risk stratification more accurately than we can do with clinical features alone. Can we confidently tell a patient who's truly low risk that they can be watched? Can we confidently tell a patient who's either intermediate or high risk that they need to do either an invasive biopsy or perhaps the most appropriate thing would be for surgical resection for cure? There's a lot of good foundational science behind the idea of using a nasal classifier and the genomic information that you can get from the nasal epithelium to inform the risk stratification process for a patient with a pulmonary nodule, specifically a patient who has smoked. This utilizes the field of injury principle, the idea that the damage done by smoking that leads to carcinogenesis in a lung nodule can be detected throughout the respiratory tree. Avi Spira published in Nature Medicine in 2007 the idea that gene expression from airway epithelial cells in the right main stem bronchus could serve as a lung cancer biomarker in a current or former smoker. This obviously led to the Percepta GSC. This was published in the New England Journal of Medicine by Jerry Silvestri and led to the bronchial classifier and then the subsequent Percepta GSC classifier that I just described. The field of injury principle was further extended and shown to actually occur in the respiratory epithelium that occurs in the nose. Perez Rogers and colleagues showed that this airway epithelial field of injury could be detected in the nasal epithelium and serve as a lung cancer biomarker. And this work was presented as proof of concept by Dr. Lamb herself and colleagues at CHEST in 2019. I'm very proud to say that Verisight was able to present the final clinical validation data and the performance characteristics of this classifier at ASCO just a few weeks ago. So what's been going on in those interval 2 years? Well, the fact that this is a very simple office-based test sort of belies the fact that underneath it is an enormous amount of complexity. In order to make the classifier perform the way it needs to perform, Verisight enriched the training cohort with additional patient samples, took patients from a more diverse patient populations than was initially available in 2019, nearly doubling the size of the training set. And they enhanced the algorithm by building sort of sub-algorithms, these genomic indices to inform on specific technical factors and clinical factors like variable cancer stage, cancer histology, nodule size. The training set consisted of over 1,100 patients, all current or former smokers. The final algorithm used gene expression from the brushings of the nasal epithelium combined with clinical factors in the same paradigm shown in the final slide in Carla's talk. The clinical factors used in the classifier are age, past years, years since quitting, nodule size, and nodule speculation. And ultimately, 502 genes were in the final locked classifier. All patients were followed for at least a year or until a final diagnosis of cancer or benign disease was made. And then finally, the performance of the classifier was validated in this independent validation set, independent test set of 249 patients from, again, a diverse set of cohorts. This is our final poster. I'm not going to go through this in detail, but I am going to go through some of the figures and then the final data with you. This is the consort diagram that shows how patients were prospectively grouped into the allocation and validation sets. Over 2,000 patients, we had just under 2,000 patients who were evaluable, and they were allocated prospectively. The validation patients were set aside prospectively so that the computer had absolutely no knowledge of the outcomes of those patients, leading to the 249 patients in our validation set. On the right, you see table 1, which shows the characteristics of all of the benign patients and all of the patients with malignant disease. As you can see, the groups of patients are different. There are expected clinical and radiographic differences from benign, comparing the benign and malignant patients. The malignant patients tended to have a higher smoking burden. The malignant patients tended to have larger rather than smaller nodules. The malignant patients tend to have more spiculated nodules. All of the things that we would expect associated with cancer. But again, the nasal classifier is using genomic data to build on top of the performance using these clinical characteristics alone. The other thing that I will point out is that this is a group of patients very, very heavily enriched with cancer. So prevalence of malignancy in this validation set is 54%. If you're going to train a computer how to distinguish cancer from non-cancer, you have to show it a lot of cancer. So we'll see in the next data slide the relevance of that very high prevalence. It allowed us to have a very accurate classifier, but it also required that we prospectively determine that it's necessary to adjust the data to a prevalence and look at the performance of the classifier and what we expect to be the prevalence or something close to the prevalence of the clinical use of the classifier. And this is our data table summarized. The test is designed to characterize patients into low risk, intermediate risk, and high risk. And to do that, it establishes two decision boundaries, a lower decision boundary and a higher decision boundary. And that is advantageous because it allows the lower decision boundary to have a very high sensitivity and exactly what you want for a rule-out test. And it allows the upper decision boundary to have a very high specificity, which is what you would want for a rule-in test for each of those decision boundaries. So when the classifier, this is the final locked validation classifier validation data, when in those 249 patients, when the test identified patients as low risk, the sensitivity and specificity of that test was 96% and almost 42% specificity. That in the prevalence of 54% in the actual validation set prevalence gives us a very high negative predictive value of almost 91%. It's very, very high prevalence. It is actually able to say with a high level of confidence that a patient gets a low-risk result does not have cancer. It's remarkable in a population with a prevalence that high. When you extrapolate to patient population, this was done mathematically, and extrapolate to a patient population of 25% cancer prevalence, the negative predictive value of that low-risk result is even higher, over 97% negative predictive value. This classifier at that low-risk cutoff is essentially classifying over 40% of all patients with benign nodules as low risk and missing just less than 3% of all cancers. And the vast majority that were not classified as low risk were classified as intermediate risk. When the test identified patients as high risk, the sensitivity of the test was 58%, but the specificity was over 90%. That gives us a positive predictive value of almost 88% at the 54% prevalence of the validation set. And when you extrapolate to a lower prevalence, 25% cancer prevalence, you still have a very high positive predictive value exceeding the 65% threshold cutoff for calling a patient high risk in the ACCP guidelines. So excellent performance at the high risk, excellent performance in terms of negative predictive value at the low risk. And 57% of all patients were categorized as either low risk or high risk, meaning only 43% of the patients were in the intermediate risk category, with very few false negative, very few false positive patients, very few cancerous patients with cancer labeled as low risk, and very few patients with benign disease labeled as high risk. And that is the data that we have presented, that Verisight has presented at ASCO, the first of its kind, easy-to-use, office-based genomic test that can accurately classify patients in terms of their lung cancer risk. They can actually bring objective data to the risk assessment in a newly identified pulmonary nodule in a current or former smoker. We hope this allows more patients, we suspect that this will allow more patients to avoid unnecessary invasive procedures when they truly have benign disease, and will, we expect, accelerate the time to diagnosis and treatment, the time to cure for more patients with lung cancer and early stage disease. As I showed you, this is all part of Verisight's comprehensive lung cancer portfolio. The third part of the portfolio, which I did not discuss in the earlier slide, was the Percepta Genomic Atlas. Just a few seconds about that. That is a RNA sequencing and targeted DNA sequencing that is designed to provide genomic data to speak to the targetable mutations in a patient with cancer. And it's a test designed specifically, it's a next generation sequencing platform designed specifically for lung cancer biopsies, those done by bronchoscopists and those done in the interventional radiology suite. It covers all of the 9 recommended targeted mutations that should be screened according to the NCCN guidelines, plus a panel of other common mutations, and that is something that Verisight will be proud to launch later this year. So our topic today is the nasal swab classifier. As I said, this has a very high negative predictive value for at the 25% cancer prevalence for patients with benign disease, and a 67% positive predictive value. And Dr. Hans Lee is now going to join us to talk about how one might incorporate the nasal swab classifier in clinical practice. Dr. Lee joins us from Johns Hopkins University Medical Center in Baltimore. He is the director of the Interventional Pulmonology Fellowship at Johns Hopkins. He is the director of bronchoscopy at Bayview Medical Center in Baltimore, and I'm pleased that he is here today to talk about incorporating this risk classifier into clinical practice. Thanks, Dr. Lee.
Great, thank you. It's a pleasure to be here, and I will be discussing how this type of technology could potentially be incorporated into clinical practice. But before I get into that, I'd like to share an observation of this case that Dr. Lamb presented. And polling had about 60% of people placing this in the moderate risk, with the other 40% presenting this either in the high risk or low risk. And I'm not surprised by the variety of answers that came back because management and risk assessment is complex, and many of us have different experiences with very, very similar cases. And so the challenge of these types of cases is understanding what the risks are, and then trying to communicate that with our patients. And this is our current workflow, and we get the pulmonary nodules from a variety of sources, the majority being from our PCP, our pulmonologist, the emergency room, as incidental nodules. We get a smaller number, but growing number, from lung cancer screening, where these patients may have a nodule seen on a CT scan. Then those patients and the CT scan makes its way to physicians like myself, healthcare providers, and we discuss a lot of the things that Dr. Lam discussed, and we come together with a kind of a shared decision-making discussion with our patients on what are the potential options, which can include bronchoscopy, CT-guided biopsy, interval imaging, or even surgical biopsy. So this is our current workflow. And in that workflow, with our discussion with our patients, we usually engage them in this type of shared decision-making model, where we elicit the patient's values and goals, and then discuss the pros and cons of all of those options that we just saw, and then come together with a final decision. And this form of shared decision-making model is not uncommon not in pulmonary nodule management, but any type of disease process that has to deal with clinical uncertainty. And I think that's the big thing here with clinical uncertainty, because when we have moderate risk patients, it means that they can go in either of one of two ways, a binary decision, malignancy or non-malignancy. And the ramifications are quite broad. So where this type of technology, the nasal swab, can come into potentially in our clinical practice will be before the decisions of bronchoscopy, the biopsies, or interval imaging. Again, these patients are coming to us, and having that type of information could potentially change the discussions that we have with our patients in that shared decision-making model that I just went over. So diving a little deeper into that discussion with our patients, the nodules can potentially, again, come to us, and we can either use this particular test in a discussion when the patient is present in our offices, or now via telemedicine, where we can discuss the test with the patient, find the result, and then make our decision on should we have additional diagnostic imaging versus an actual invasive procedure. Another potential way to incorporate this technology into our practice would be through something like reflexive testing, or when we get a referral for consultation, oftentimes the visits aren't made instantaneously, giving us a little bit of time to potentially order the test and have the test results ready and available by the time the patient meets with us in our offices, so that we can come together and make that shared decision-making process. I think another interesting process that could potentially occur is through reflexive testing. Questionnaires are fairly common for our patients as they go for nodule screening on the day of their CT scan. They're often asked to fill out a questionnaire with some demographics, interest in things like smoking cessation, counseling, and products. Patients will get their CT scan, and if they screen positive, potentially that questionnaire could also ask ahead of time that if a patient screens positive, would they be interested in a nasal swab to further assess their risks for lung cancer. That way, that data and information can be available to the physicians by the time the patient comes in to discuss the results of their CT scan, as well as additional risk assessment with a genomic classifier. So coming back to the shared decision-making model, with all the information that we've had that was very similar to Dr. Lamb's case with the CT scan results, demographic results, if we also had a genomic classifier at this point of the timeline, we could discuss with the patients what the results of that genomic classifier is, in addition to, of course, listing their values and goals, and I think decrease the clinical uncertainty that we face with pulmonary nodules. Right. And I will give the floor back to Bill.
Thank you to Dr. Lee for that perspective. And I'm going to now open up the forum for questions. If you could submit your questions in the question box. Okay, yes, so we have a question from one of the attendees for Carla, and they wanted to know what was the ultimate diagnosis in the first case that you showed.
Yes, so just to highlight, again, this patient kind of stratified into the intermediate risk category, and he happened to have a PET scan that showed faint uptake less than SUV of 2. If we work our way through the ACCP guideline algorithm, that would kind of create a branch point, taking into context the PET scan, either option of short interval surveillance versus non-surgical biopsy. Again, keeping in mind this patient had a non-surgical biopsy bronchoscopically that was not conclusive. And so we came back to shared decision-making, and we presented him these options to include a TTNA, surveillance, and then ultimately he inquired about surgical biopsy. And the patient actually ultimately chose himself, after hearing all those pieces of information, surgical wedge resection, and it was a granuloma. And so I think again, this is where you kind of go back and think, well, would this nasal swab may have been something that would have informed him in terms of his choice. But I think it exemplifies, even with following the guidelines, this is still our challenge, I think.
Thank you very much, Dr. Lamb. I would say that have been a challenging transthoracic needle aspiration. Obviously, it was a challenging bronchoscopy, and that clearly I sort of highlights how additional objective data could potentially inform the decision-making process for these types of patients. So we have a second question that I'm happy to answer, and that's, is this going to be, the webinar will be available on demand? And the answer is yes, it'll be on the ATS website on demand. And then we have two people that are asking about insurance and coverage. We've just very recently presented the validation data, and the test is in the process of being launched. We've not yet determined, Verisight has not yet determined what the price for the testing will be. Are there confounders like URI that might affect the results? I think that I would feel that the population of patients the 1,100 patients that were in the training set was a very diverse population of patients. Some of them were patients undergoing bronchoscopy in the Aegis cohort. Some of them were patients undergoing screening in the Leahy cohort. 11,000 patients. Many of those people had their tests done. All of those people had their tests done in real-life conditions, and I'm sure many of them had confounding things like URI. Those are some of the sub-indices were built to address that, to enrich the algorithm so that it could account for the enormous heterogeneity of cancers and the heterogeneity of patients being tested for cancer. There is a question about insurance and Medicare coverage. Obviously, we're going to be pushing very aggressively to collect this type of clinical utility data as this test is launched to be able to go to insurers, to be able to go to CMS and say that this is a test that is worth covering. All right. What is the turnaround time of the results? So The turnaround time of the results probably will be around 7 days. That is obviously time in which you may have, as Dr. Lee pointed out, done the test prior to the visit, the consultation with the pulmonologist. I know in my practice, the turnaround time for a nodule patient was somewhere about 1 to 2 weeks. Dr. Lee, how long does it take for a patient to get to see you in the office generally for a lung nodule that's in that less than 30 millimeter category, would you guess?
Or it's usually roughly about a week as well, 1 to 2 weeks.
So even if it was done at the time of the pulmonary visit, in general, you're going to have a long discussion, a shared decision-making discussion with a patient, and you're going to tell them about the test and what the potential results will be, low, intermediate, and high. And when that data comes back, you'll have a secondary discussion with the patient. How does this new piece of information either confirm our predicted plan, or how does it change our predicted plan? The turnaround time is also going to vary, I'll say, just with the volume of testing. If this is a test that's in widespread use, the turnaround time will obviously be shorter, and I'll leave it at that. So. I'm having difficulty. Oh, what was the diagnostic first case of the incidental nodule? So that's, does Verisight have a nasal swab test for diagnosis of, and I don't see a secondary, an end to that question.
I think it says for interstitial lung abnormalities.
Okay, sorry, yes. And the answer is yes. So specifically for distinguishing patients who have suspected or possible UIT. There's a test, the Envisia genomic classifier, that utilizes tissue obtained from transbronchial biopsies sent to Verisight for RNA sequencing, and that has a good classifier performance for determining UIT from a UIT phenotype from a non-UIT phenotype. And are there any additional questions? All right. Well, if there are no more questions, I thank you all for coming, for joining this webinar. I would like to just yield the floor to Dr. Lam, who is gracious enough to join us today. Dr. Lam is one of the co-founders of the Rescue Lung Society and has an upcoming conference of her own. And I'd just like to give her, since we have a few minutes left, an opportunity to advertise this to you. Obviously, if you're watching this later on demand, the conference may have passed, but for those of you here live, I'm happy to offer this time to Carla.
Thank you, Dr. Bullman. I just would like to introduce that we have a June 25th and 26th, we have a virtual Rescue Lung, all things lung screening with international speakers with all the updates in one comprehensive set of two-day webinar. And you can go to our website, www.rescuelung.org, and I can type that into the Q&A just so you have that. But we would love to have you. I think it's meant for those who are passionate about pulmonary nodules and lung CT screening. We'd love to have you.
Certainly, the medical team and the clinical team and the R&D team at Verisight are very passionate about lung nodules and screening. It's our intention to partner aggressively with lung cancer screening programs so that more patients have access to accurate risk stratification, more patients with benign disease get told with confidence that they don't need to worry, that they need to go into surveillance, but that their level of anxiety should be low, and more patients with cancer get definitive treatment, ablation, cure with surgery in a timely fashion. So thank you both to Dr. Lee and to Dr. Lam, and with that, I will close our session. Thank you.
Thank you.
Thank you.